Presenting for us today, we have Dr. Molly Billings. She's a professor of medicine in the Division of Pulmonary Critical Care and Sleep Medicine at the University of Washington, and she specializes in pulmonary and respiratory disease care, sleep disorders, and sleep medicine at the Harborview Medical Center. And then after she gives her presentation, we're going to have Dr. Chow is going to present a case study, and Dr. Chow is a professor in both the departments of medicine and pediatrics at the John A. Burns School of Medicine, and he's an internal medicine doctor with the Queens Medical Center. Just a few of the things they do. All right, so if we want to go ahead and start with Dr. Billings.
Great. Thank you so much for having me. I look forward to talking to you about sleep abnormalities and long COVID. Can you all see my screen okay? Yeah? Okay. Um, let's see if I can advance my slides. That's the next problem. Okay. Well, let me try something else. There. Okay. Um, so I have nothing to disclose. And the other thing I will say is that I like art that reflects sleep. So you'll be seeing lots of pieces of art that throughout for different cultures and different peoples featured here. So during this talk, my objectives are to kind of go briefly, I'll just touch on the basic biology of sleep and how long COVID may impact sleep and the kind of the hypothesized mechanisms of how it disrupts sleep. We'll kind of get into more details about the different manifestation of sleep disturbances in long COVID. And then we'll get into how to approach it clinically and my approach for the workup and treatment. So sleep, as you all know, is a basic need that's necessary for life, and it's preserved across all species of animals, including even insects. It's highly regulated, and it goes through different cycles. So you have different stages of sleep, and it's very prescribed. And so it's if you don't have enough sleep, then you have impaired performance, impaired cardiovascular health, impaired metabolism. And in order to have healthy sleep, you need to have adequate sleep in quantity as well as highly efficient sleep, good quality, and appropriately timed in your circadian clock. And it should result in you feeling rested and alert. And this is just a sample hypnogram, which is just over the night, kind of what the different cycles of non-REM and REM sleep that your body goes through in a normal, healthy adult. Sleep and wake is highly regulated in the brain. It is through two different drives or two different processes that interact. One is the sleep load that accumulates as the day goes on. So the longer you've been awake, the more your sleep load is. And then once you go to sleep, you can pay that off until you wake up again. And so that's your kind of homeostatic sleep drive. The other aspect is called process C, which is the circadian rhythm, and that's regulated by the SCN in the brain and the hypothalamus, and that is releases signals to promote wakefulness, and those signals kind of increase as your sleep load increases. So for me, right now it's 7 o'clock at night, and I have been awake all day, but because my circadian rhythm is highly active, I'm very alert, but it'll slowly peter off, and then that's when I will sleep at night. So these two processes need to be aligned for people to have normal, healthy sleep. So long COVID, as you all know, has very prominent symptoms of sleep disruption and fatigue. And so as this emerged, it became more apparent that long COVID almost uniformly impacts sleep. So here's some of the early studies. Very, very early on in Wuhan, China, they studied survivors of COVID who were hospitalized, so had pretty severe COVID. And they were followed for 6 months, and they did quite a lot of assessment of them, mostly for their pulmonary disease. But most of them report, or not most of them, a good chunk, 26% reported persistent sleep difficulties, even after all their respiratory abnormalities resolved. Um, and this is similar to things, observations of prior viral pneumonias, such as influenza and SARS that had ARDS. And these are not necessarily long COVID sufferers. These are just all comers who survived COVID. But just to reflect that there's a very large proportion that have persistent sleeping problems and fatigue and not so much respiratory problems or dyspnea. This again was another early look at what happens after acute COVID, and sort of the post-acute COVID syndrome. And in those groups, 53% suffered from sleep disturbances alongside cognitive brain fog, headaches, some of these other fatigue, low quality of life, other symptoms. This is another study. This was in Germany, kind of later in the pandemic. And these folks completed questionnaires about 3 to 9 months after their acute COVID. And this is sort of an early sort of rating of long COVID. And again, very, very high prevalence of sleep disturbance, second only to fatigue. This is a kind of larger study, just looking at the overall burden of long COVID or post-acute sequelae of COVID. This was a huge cohort study of veterans who survived 30 plus days compared to controls. And they estimated that among all of these veterans, there was a 7% of infections led to long COVID. And among these, the very highest prominent feature was sleep disturbance. And you can see that it's just underneath shortness of breath. And it's sort of across all different age groups, a little bit less common more common in younger people, and with more comorbidities, more prevalent. Um, Now we've sort of come to realize this crossover between long COVID and similar symptoms in myalgic encephalopathy and chronic fatigue syndrome. This was a decent sized study at Stanford. And these are people that were not so much hospitalized, but more just people that had had COVID almost a year out. And of those, about 20, a third had criteria that would meet diagnostic criteria for ME/CFS. And fatigue, post-exertional malaise, brain fog, and unrefreshing sleep are kind of, if you look at that red box, those are the very, very common and very severe symptoms that are sort of prominent in this group, with insomnia, unrefreshing sleep, and fatigue being kind of top of symptom burden. So why do people have sleep as part of this group of symptoms in long COVID? And these are hypothesized mechanisms, haven't been firmly established, but there's some early science suggesting. Of course, we don't really understand long COVID exactly well. So there are these kind of things that go along together, right? With cognitive impairment, fatigue, disordered sleep. That's thought to be reflective of dysautonomia, neuroinflammation, cerebral blood flow changes due to the dysautonomia, and then the small fiber neuropathy. But how does that lead to sleep problems? Here are some sort of recently kind of identified possible scenarios. So one is that these pro-inflammatory neuroinflammation with the cytokines, interleukins 1 and 6, TNF alpha may impact that sleep architecture I was telling you about, moving through REM and non-REM. Could be that microclots and this systemic inflammation compromise the blood-brain barrier. We do know that the virus, COVID virus, often goes through the brainstem via the olfactory bulb, which is really rich in these ACE2 receptors. And there are a lot of those receptors within the hypothalamus. And this is possibly leading to damage of the orexin receptor cells, which regulate sleep, wake, and REM. And that may affect sleep, wake regulation. It may also lead to some of these microclots and inflammation may lead to impaired lymphatic system. And the lymphatics are important during sleep. They're kind of like the lymphatic system of the brain and help clear toxins and things that are associated with building up of toxins that could lead to Alzheimer's. So this may be kind of the mechanism for brain fog. And then maybe perhaps the dysautonomia may lead to increased sympathetic and not enough parasympathetic tone, leading to more hyperarousal as well as impaired CNS perfusion. Um, Here's a kind of interesting study that was sort of a study of happenstance. They were doing a study in a rural Ecuadorian village that around the time of the COVID pandemic, and about 50% of this village contracted COVID all at once in early 2020. And these folks had, prior to this infection, had baseline MRIs and had filled out questionnaires about their sleep. And then about almost 100 of them had this baseline MRI questionnaires, got COVID, and then had a follow-up MRI about a year after that. And of those, about 26 reported poor quality sleep by the Pittsburgh Sleep Quality Index, which is kind of a common index that we use to measure sleep disturbances. And after adjustment for common things such as age and BMI, poor sleep was associated with changes on the MRI of enlarged perivascular spaces. And the perivascular spaces get enlarged when there's impaired lymphatic flow and accumulation of metabolic waste. And this is an image from the study just showing that this is sort of before. I don't know if you guys can see my cursor, but there's no enlargement. And then on the follow-up MRI, the T2 weighted MRI, you can see near the ventricles along that, there's accumulation of perivascular fluid and enlargement, sort of suggesting that lymphatic impairment. Quite remarkable in one case. So these are kind of ways to think about it. So you get infected, you get, in some people it resolves and it's not a long-term problem, but in some you get this post-infectious sequela. And then those in turn, due to those inflammation, the neurotoxins, maybe the lymphatics, you have impairment of the hypothalamus pituitary axis, impacts on clock gene expression, which is kind of the regulation of your circadian rhythm. And all of those can lead to sleep disorders, chronic inflammation, and these downstream effects on sleep. And all that can be influenced by, your baseline health, your nutrition, and other comorbidities. And of course, the virulence of the virus. All right. So in terms of characterizing sleep issues, and this is a picture I took when I was in India, by the way, just of the sleeping Buddha. So recently they've tried to sort of better assess what are the features of long COVID and what kind of sleep issues they have. And this was like a really recently, I don't think it's out in publication yet, but it's like a preprint. And they collected surveys of about 10,000 people with COVID, and they're trying to sort of find the prevalence of long COVID using these different formal definitions. But they found that among those that kind of met this long COVID definition, they were more likely to report insomnia, poor sleep quality, and a short sleep duration after adjustments for baseline factors. So those who had poor sleep quality were much more likely to have long COVID. It's not clear if that was prior to or after they got COVID based on their methodology. The Cleveland Clinic did another study of long COVID patients, again, kind of in the second phase of the pandemic, and they use the metric of the PROMIS questionnaires, which are a little different than the PSQI, but similarly kind of on their sleep symptoms. And again, high prevalence of moderate to severe sleep disturbance. they found in their population more likely if you were hospitalized for your COVID and identified as Black race, and also associated with anxiety and fatigue. This other more recent study of long COVID, again with a very large sample size, multinational, so 16 different countries in 2021, looked at pre-pandemic symptoms and found that people before contracting COVID, those that had insomnia had a higher risk of long COVID. And on the flip side was also true. If you had long COVID, you were also at higher risk for developing insomnia. So the adjusted relative risk was twice that. And 66% of people had incident insomnia in this population. So one other factor that's been looked at is sort of what happens over time, because we know that a lot of long COVID symptoms improve with time. And this was looking at sleep symptoms. So this was about 133 long COVID patients that were at a clinic in Greece, and they had been hospitalized for their COVID, so pretty severe pneumonia. And they assessed their sleepiness with the Epworth Sleepiness Scale score, the sleep quality, and then this Athens Insomnia Scale score, and they measured them at 1 month, 3 months, and 6 months after discharge. And basically, all of their sleep symptoms did get better over time. The first month was the worst, and it was not associated with their baseline COVID severity. So about a third had moderate to severe insomnia, with again fatigue and poor sleep quality being very, very prevalent at 1 month. But by 6 months, it was just about a quarter of these subjects. So improve with time. The other feature besides insomnia and poor sleep quality that's common is restless legs. This study was done via recruiting cases from a long COVID Facebook group. And most of the people were white, mean age of 47. And it was sort of a case control study looking at the prevalence of restless leg syndrome. And they found that restless legs was very common or more common in those with long COVID than in controls. And they assessed pre and post COVID sleep symptoms and medication use. And again, not associated with their COVID severity, if they were hospitalized, or if they were taking any medications. So all of these sort of studies on the symptomatology of the sleep symptoms in long COVID kind of informed the RECOVER trial, which is currently underway. And this is kind of a study meant to sort of figure out if we can help people with long COVID and treat their symptoms. And so based on the high prevalence of sleep symptoms and the type of symptoms people have, which are feeling fatigued and also insomnia / sleep-wake cycle issues, they kind of put together this protocol for assessing them. So what they're doing is enrolling patients, obviously with a history of COVID, that now have new or worse sleep problems since they're infected that has persisted about 3 months after their initial COVID infection. And they have enough sleep problems that it's impairing their daytime function. And they have two different groups, one with more symptoms of insomnia. So insomnia being difficulty getting to sleep, staying asleep, just feeling like your sleep quality is poor, or having irregular sleep-wake timing. And then kind of on the flip side of that, they're also looking at people that have very prominent sleepiness. So not just fatigue, but the trouble staying awake and feeling sleepy. They plan to take all these folks that qualify, screen them for sleep apnea by doing a home sleep apnea test. And the plan is to enroll about 1,000 participants and over 34 different sites. And it's kind of a complex multi-arm randomized controlled trial based on the phenotype that I described. So if they are in that insomnia phenotype, so people that have what they've termed complex task-related sleep disturbance, so that's folks that have trouble getting to sleep, don't fall asleep at the same time every day, thinking perhaps there's a component of sleep-wake circadian rhythm abnormalities contributing to their insomnia. The plan is to do a trial of melatonin compared to no melatonin and light therapy compared to no light therapy and kind of all the different combinations. So there's 4 different combinations that they're going to trial. Um, and they're going to do like a sham low intensity versus high intensity light therapy. And light, as you probably know, is a very important part of anchoring your circadian rhythm. And your suprachiasmatic nucleus gets that input from the retina to regulate, your circadian rhythm. And that, as I mentioned, that process C and process S, that's the important aspect to regulate that. So that's that trial. And then if they determine that the patient is more of a hypersomnia or excessively sleepy phenotype, then they're going to randomize them to either modafinil or placebo for 10 weeks. And then they're also allowing for solriamfetol in a subset of people that can't take modafinil. And the outcome is their level of fatigue, their insomnia, their cognitive function. They're going to have people wear activity trackers and complete memory and attention tests and sleep diaries. So that's to be determined. So just quickly, I'll go over what I usually do when I have sleep patients in clinic with long COVID, which is a very common presentation of folks. As you know, fatigue is multifactorial. So I kind of usually in sleep clinic kind of make, in my mind, kind of run through the other causes of chronic fatigue. And then if it does seem like a sleep prominent disorder, then I try to put them in one of these following buckets. Does it seem like their fatigue and sleepiness is due or is related to issues with breathing during sleep, so that they have snoring, gasping episodes, breathing pauses? Then I think more about sleep apnea, which is extremely common. Is it more in the timing, falling asleep at the wrong time, difficulty getting to sleep with a delayed sleep onset? Then I think more of a circadian rhythm issue. Is it more sleep fragmentation, difficulty falling asleep, which can be difficult to separate from circadian rhythm, but sometimes there's just frank insomnia. And then I will ask about restless leg symptoms, such as the urge to move or stretch that's worse at certain times of day. Or are they more that phenotype that's excessively sleepy, napping a lot, falling asleep unintentionally? And sometimes they have multiple of these different buckets, but these are all things that I know how to treat. So once I kind of distinguish between those things, if I suspect sleep apnea, we often do a sleep study, typically a home study. And then I often recommend CPAP, continuous positive airway pressure. If they have more of this urge to move the legs, that's worse at night, I will check their iron stores, because low iron is associated with restless leg syndrome. And if their iron stores are low, their ferritin level is low, I'll give them supplemental iron, or if not, then often we start them on gabapentin to help improve their sleep. If they have a more prominent insomnia phenotype, so they have trouble and kind of associate not sleeping well with going to bed and are kind of anxious about sleep, the most effective treatment is cognitive behavioral therapy for insomnia. These, there's definitely, I've had challenges in this, in these treating people with long COVID, because a lot of the therapy includes restriction of time in bed and stimulus control, which is difficult for someone with long COVID and who can't get out of bed and needs to lie down because of their postural symptoms. So this can be a tricky spot here, but that's kind of the goal. And then for hypersomnia, like I said, difficulty staying awake and difficulty concentrating, I usually use drugs that are often also used for narcolepsy or idiopathic hypersomnia, such as Nuvigil or Provigil, solriamfetol, and Wakix is a newer one on the market, which I've never gotten approved, and then some off-label drugs that that they use for ADHD, such as atomoxetine and Vyvanse, as well as other normal stimulants like Ritalin and Adderall. Those I try not to use as much because they're very, have a lot of side effects in terms of your heart rate and blood pressure. So usually I'm more using the modafinil. And then these are the recommendations of the USME CFS Clinical Correlation Coalition. And so these could be tried as well. Again, light therapy, trazodone and oxypen for insomnia, meditation, relaxation, and then insomnia with pain. If pain is contributing, then low-dose naltrexone, the gabapentin, and duloxetine are also good options to try. But basically, we don't know the best treatment for long COVID related sleep symptoms. So they are extremely common and kind of basically fundamental to long COVID. And now at this point, we don't really understand the cause or the treatment, but so we're kind of focused on symptom assessment and kind of phenotyping them, probably related to similar pathophysiology to MCCFS. And so right now, I just direct my therapy to similar symptoms that have been already characterized, and we'll wait to see what the Recover trial shows us in terms of any of those options efficacious. That's it. Any questions? Thank you. And there's my references.
Thank you so much for. I was just wondering the lymphatics was lymphatics system. Do you think that that is like one of the mechanisms, or do you think that it's just happened to be associated with just the findings of the sleep issues and issues that require I guess the lymphatics for the brain itself to kind of improve. Do you think it's something? We have a neurologist who does MRI scan and also CT venous CT scans. I didn't know. He often talks about how the poisons in the brain needs to be flushed out during the evening hours, and he always suspected that that's the reason why people have brain fog. I'm interested to hear what do you think? Is that something that's like very new to us? We always think
it is new. It's kind of an emerging field, really. I've heard a couple lectures on lymphatics recently in relation to sleep apnea, because similarly in sleep apnea, you don't have the rest you need. And so it's hypothesized that it's impairing lymphatic drainage because you're, getting these alerting symptoms all night long. But it kind of makes sense to me. Also for long COVID, if there is that neuroinflammation and, damage to the blood-brain barrier and the lymphatics drainage system, that these things could accumulate and cause much like we think they're related to Alzheimer's. We don't know, but we see the accumulation of the beta amyloid proteins in people that are not drained through the lymphatics. So it makes sense to me that would cause cognitive issues and without having proper sleep. But yeah, I don't know.
Interesting. Melissa, could you pull up the slides? Other people who have a quick questions while Melissa's pulling up the slides? So I'll just jump in and just present the case and get your feedback into a case of what we have here in at the University of Hawaii. So Melissa, next slide. So it's a patient of ours who's 45-year-old female, has a history of anxiety, depression, interstitial cystitis, has obstructive sleep apnea in the past, status post UPPP procedure, history of gestational diabetes and diverticulosis, was a former smoker, no current alcohol use, former marijuana use, single, lives independently, had several episodes of COVID, not hospitalized, no supplemental oxygen needed during her episodes of the acute COVID. Always has main symptoms of persistent fatigue, unrefreshed sleep, and then worsening sleep abnormalities since COVID infections. And so has chronic fatigue, brain fog. Sleep disturbances include that of non-restorative sleep, as you could see, despite more than 16 hours, but still unrefreshed. Daytime somnolence, fragmented sleep, sometimes due to urinary frequency, migraines, muscle pain, and then night sweats. And then she will talk about heart rate going excessive, maybe into the 150s during sleep, because she has a tracking device that she looks at. And then she'll look at the heart rate variability and often see that this is declined and perhaps suggestive of some autonomic dysfunction. She has tried using some sedatives in terms of diazepam for sleep initiation, but still has really excessive daytime drowsiness. Intolerance of CPAP in the past, does use an oral appliance at this time. And then she'll have these PM episodes where she'll have recurrent flares. She has dysautonomia. We did have a dysautonomia clinic here, was diagnosed with POTS, in orthostatic intolerance, migraines, and then has a coat hanger myalgia that she often will say is she'll complain about. Next slide. And then so her vitals were stable. Does run into high blood pressure, especially when we saw her. Her MoCA was mildly impaired, despite being a college graduate. She has a frailty score. And then on regards to her sleep study, she has a OSA AHI of 16, but still have residual persistence. Normal brain MRI echo showed mild diastolic dysfunction, and then she had a normal renal duplex. Cortisol was intermittently low, similar to many of our other long COVID patients. And then she wears a wearable device. And we talked about the reduced heart rate variability. Just follow up in terms of multiple visits since 2022. She tried propranolol for her orthostatic intolerance. She did also use the Florinef. She has more recently used droxidopa with some partial benefit, and has stopped low-dose naltrexone due to some side effects. As we mentioned, the diazepam for insomnia causes her daytime sedation. Sound therapy, she has used TMS, and then sleep hygiene. She understands about using adjustments and trying to pace herself. Still has wax and waning symptoms, and then she would have these PM episodes that we talked about in right before. So next slide. So obviously you touched base on many of the mechanisms, perhaps autonomic dysfunction, the inflammatory immune dysregulation, neuropsych in terms of anxiety, depression, and then obviously she has OSA from diagnosed in the past, and then currently doesn't use CPAP, but does use an oral appliance. So our questions was, do we repeat the sleep study to try to reassess the OSA and evaluate for sleep fragmentation and arousal and the sleep muscle restless leg that you just mentioned? And then you mentioned about the CBTI. the pacing and the low-grade melatonin. And then we're a little bit more cautious about the use of benzodiazepine for her. How much does autonomic dysfunction contribute to her sleep, and will treatment of her dysautonomia improve her sleep pattern? And then the role of mental health support in terms of how it could help her sleep, as well as also for her overall mental health status. And then would you recommend wearable devices to try to track sleep, and how much of a process do you do in terms of, how much do you rely on those heart rate variability monitors? So I think those were our questions in regards, if you could help us kind of help her through her sleep
Sure.
issues.
Yeah. Well, one thing I always wonder if she has underlying sleep apnea from prior to her COVID, is that did that affect the severity of it? So I often will recommend repeating it because it can affect maybe with the change in tone of the upper airway or regulation of breathing. So I would want to make sure that that dental device, the mandibular advancement device, is working. So I would probably have a low threshold to repeat that if she's having ongoing symptoms. Oh, you stopped sharing. I was trying to remember the other questions were. For her insomnia, I g- generally almost always don't recommend benzos, just regardless of thank you, um, because um, because it can worsen sleep apnea, and there's a risk of dependence, and then also can sort of interfere with you can psychological dependence. And you have that sort of lingering daytime symptoms. So if you were to use a sleep aid, I would recommend kind of thinking about one of the ones that I brought up before. So maybe gabapentin or duloxetine, or maybe trazodone, to kind of help with the pain, the discomfort, as well as help with sleep. If CBTI is not, or yeah, in conjunction with CBTI. CBTI, like I said, is the most effective, but can be challenging in patients, especially with a lot of dysautonomia that can't do the avoiding staying in bed. So, people use medical marijuana. I don't like people smoking at all, but sometimes edibles. Not that I'm not recommending that, but I'm saying those are options that people try. I do think that mental health support is critical because, as you guys probably all know, sleep is highly tied into mood, right? So if you don't sleep well, it can make you feel more anxious, then it's harder to get to sleep. Same for depression. Depression, often a big sign of it is difficulty staying asleep or waking up too early. So, and of course, suffering from some of these symptoms can make, worsen mood symptoms. So I do think it's really important to address those. And then in terms of the wearable device, uh, I find that people that are sort of obsessed with data, um, can be a little bit harmful sometimes because people get kind of hung up on the numbers. Um, and I work at Seattle, so we have a lot of tech people that are like computer IT type folks that are really focused on, oh, and my watch said, I only got so much percent. And really, the important thing is how they're feeling. So I don't recommend monitoring personally, because I feel like it can be harmful in some cases. So I think, so I would sort of not have her focus on that. But I do think it'd be worthwhile to do a multimodal therapy. Consider repeating the sleep study. And then if you need to help her sleep, um, in terms of medication, I would not use the diazepam. And as someone in the chat wrote, yeah, they can cause worsen memory issues as well, and the seizure risk is not insignificant. So I would use a different agent for insomnia. And I think the ones I've used suvorexant, which is a newer agent that acts on the orexin receptor in some patients that I have with other neurologic issues, and I think maybe a little bit safer, or zolpidem, Ambien. All those have side effects and can worsen sleep apnea. So you kind of have to weigh the risks and benefits with the patient, but there's not really an easy fix, obviously. Um, but that's sort of
Have you used like two different sleep aids, one for arousal and one for sleep, or is that generally not kosher to for sleep
Yeah,
people,
I have
sleep
done it, and
experts?
it's you're right. It's you rather not. You rather be pure, and but I have done that in folks to help them stay awake during the day and then help them sleep at night. Um, and sometimes by helping them be more awake during the day, like with modafinil, if they have quite a lot of fatigue and drowsiness and difficulty concentrating, then they in turn sleep better at night because they're not sort of like dozing off all day long and kind of consolidate their wakefulness. And so then they have better sleep at night. So sometimes you don't need to do both. One will then improve the other, if you will. Um, Similarly, if you get better sleep at night, then your focus is improved during the day. So, um, but yeah, I have done that before.
So we do also have a comment in here, and it says benzos can also contribute to amnesia and memory issues if not weaned, seizures.
Mm-hmm. Yeah. So there is something you can't just stop cold turkey if the person's been on it for a long time. So you do need to wean them, and the brain, benzodiazepines, if stopped abruptly, can cause seizures. EMDR. I'm not sure what do you mean by that? I don't know, you guys, what EMDR is.
Renata, can you mute and uh, might be having some technical differences while she does that. Um, in terms of in terms of uh, like TMS and you mentioned amantadine. Is that stimulatory? So you wouldn't want to give that at night. It's more stimulating in the morning and providing it.
The alerting medicine. Oh, eye movement. Oh,
Oh,
okay.
amantadine for antiviral.
Oh, amantadine. Yeah. So amantadine, I've seen people use it more in like MS and other sort of chronic fatigue slash sleepiness. I myself have not used it, but I have seen it trialed in these patients with kind of autoimmune slash post-viral hypersomnia. But I myself have not used it too much. I don't find it to be that effective in other patients that have been on it. So I more go to modafinil is usually the first line drug that I use because it's been around a long time and it's pretty safe. It does interact with birth control pills, but otherwise it can cause headaches. But um, I think it's a pretty good drug for concentration and fatigue and sleepiness.
Yeah, we've had some experience with it ourselves here. Long term, I'm not sure how helpful sometimes it is because after a while, they do all seem to improve short term for several months to a year. But then after a year or so, I don't know if often patients often don't continue it after a year and a half. I don't know if it's just fatigue of just constantly using it or what.
Yeah. Yeah, I think yeah, it kind of depends on the person and their other comorbidities. I think atomoxetine and the Vyvanse are other ones that I think might be useful in this population, that are kind of, like I said, used for ADHD primarily, but I've used them for narcolepsy and hypersomnia, and I've tried them in some of my fatigue, brain fog kind of patients as well with long COVID.
It's the EMDR stands for eye movement and desensitization and reprocessing.
Yeah,
That's
I am not familiar enough to comment. I don't know.
uh, oftentimes associated with like PTSD and psychotherapy. Um,
Okay.
and then there was lymphatics drainage therapy. Does that exist in terms of helping reduce the
No, not to my knowledge. I think the way that happens is by improving sleep and getting people to sleep. Um, but I don't think they have any like other yet discovered way to improve it, but
mm,
hopefully.
yeah.
Okay, well, I guess if nobody else has any questions or comments, we'll go ahead and give everybody back a few minutes of their day. Thank you, Dr. Billings, for joining us. I know it's later in the day for you, so we appreciate you being here. And thank you, Dr. Chow. And for everybody else, our next session is on October 14th, and it's going to be covering symptomatic treatment of long COVID.